For some of you, good afternoon. For others, good evening. My name is Brian Crowley. I'm the Senior Director of Marketing for Accelero. I'm pleased to be joined by Michelle Bianco, our Vice President of Operations. There will be two main parts to today's discussion. First, I'm going to be going through why joint replacement is a target for bundle payment, and more recently, the proposed CCJR program. Now, some of you will be familiar with this content, and for others of you, it's going to be new. In either case, we do expect that the information we provide you today will be useful for sharing with other leaders in your organizations as you're having conversations. Second, Michelle will be discussing the structure of the bundle payment programs. She'll also be defining the areas of quality and cost opportunity and the keys to success going forward. Before we jump in, just a few words about Accelero and what we do. We've been around since 1998, and we've worked with hundreds of hospitals, specifically in the area of orthopedics. In the early days, it was about helping our customers design their orthopedic service line structure and strategies. Today, our programs are built around improving performance to address today's healthcare challenges and helping our customers get ready for tomorrow's. We've worked with hospitals who are participating in BPCI, as well as hospitals who are defining and implementing bundle payment programs with their private payers. Now, I know there's still some questions around the future of bundle payment. On several occasions, people have asked me, Brian, is it possible there would be a payment for the episode of care? And my response has been yes, it is possible, and quite frankly, it was really done in the early 1980s when they created the DRG payment system. So I said to them, essentially with bundle payment, what we're talking about is just broadening that definition of episode of care. So as we go through the next few minutes here, let's spend a minute discussing why bundle payment is a target for joint replacement. In 2015, we're looking at about roughly 1.3 million primary joint replacements. In 2020, we're projecting as many as 1.9 million. Now, I know these numbers get adjusted a lot, but even if it's, say, 1.5 or 1.7 million, there's going to be a lot of demand for joint replacement going forward. And with that current demand, it's costing payers somewhere around $22.6 billion. So really, it's no wonder why payers have set their sights on joint replacement. Why else? Well, it's relatively low complication rate. It's low readmission rate. To put in perspective, if we look at congestive heart failure, that's coming in around 15 to 20% readmission rate. But the issue is when these joint replacements do have complications, they can be expensive, and readmissions can range on average from $13,000 to $17,000, and there's still more. In Pittsburgh, where I live, this is where I'm sitting right now. Many other markets across the country, maybe in your market, the payers have become the providers. Highmark Blue Cross Blue Shield acquired the Allegheny Health Network, and the providers have become the payers. UPMC here in Pittsburgh, they have their own health plan. And with that alignment of provider and payer, they are very interested in decreasing the cost of care for high volume, high cost, low complication, elective procedures like joint replacement. But there's still some more, so let's keep going. We know outside the U.S., others are doing it more cost effectively. Accelero experienced it firsthand. In the past year, we've worked in 5 of these countries that are listed on this slide. So we've seen the data, we've observed the processes, we've worked with these customers. And in some of the comparisons, we're 2 to 3 times more expensive here in the United States. So where is it that we see the difference, and where is it that we see the opportunity? It really shouldn't be anything new. If you're familiar with the study on this screen, this was published 8 years ago. It's a study that looked at Medicare total HCAHPS. And back then, some were delivering the care around $18,000, and others were around $25,000. And they said in the study, the gains were in readmissions and in post-discharge care, and we agree, and we still agree today. Blue Cross Blue Shield published this study in January of this year. So this is 8 years later, and the variability is still present. And it's not just the New Yorks, it's not just the Bostons that we see in the red bubbles, but there the variation's almost $19,000, but it's also the Norfolk, Virginias, the Lincoln, Nebraskas that we see in pink. And in those markets, there's still between $11,000 and $19,000 variation in those pink bubbles that you see on the screen. Here's another example for total hips and total knees, Dallas and Houston. Again, look at it, high volume, high cost, and most importantly, high variability in the cost to deliver the service. All right, so in comes bundle payment. It started with the CMS ACE project, and then several others followed. More recently, we heard about the proposed CCJR program in 75 markets across the country. And even if the CCJR program does not happen, these programs are not going to go away. Evidence of these programs not going away can be found with what we saw with the BPCI program from Phase 1 to Phase 2. Over 1,700 healthcare organizations signed up for Phase 1 Model 2. So just so you know, that Model 2, that encompasses the acute care and the post-acute care services. So what they did in that Phase 1, they obtained the data, they looked at the data, but then only 11% chose to move forward with Phase 2. And since the voluntary approach was not gaining traction, in comes the proposed CCJR program, right? So now I'm going to turn it over to Michelle Bianco. Michelle's going to discuss some of the relevant details associated with CCJR, but then Michelle's going to go into what we see as the keys to success with the program. Michelle, take it away.
Thanks, Brian. Let's be clear, CCJR is currently in the proposed rule stage. There are over 400 pages of the rule. The purpose of this section is to provide you with a high-level understanding of what CMS is proposing through this CCJR. CMS proposed this bundle payment approach with the goal to provide three things. First is better care through more coordinated, higher quality care. Second was smarter spending of healthcare dollars by holding hospitals accountable for the total episode spending. And third, healthier people and communities by improving the coordination of care across the continuum. CMS stated a goal of at least 50% of all Medicare fee-for-service reimbursement will be paid under an alternative payment model by 2018. This must occur through a combination of voluntary and now mandatory programs, and this is the first significant mandatory program that we have seen. The proposal is open for comment until September 8th of 2015, and we anticipate seeing a final rule on this proposal later in the fall. The CCJR program is to be implemented January 1st, 2016, which is right around the corner, and it will run for 5 years. 75 geographic regions have been chosen, and hospitals within these regions will be required to participate. So while BPCI is voluntary, this is mandatory within these geographic regions. Hospitals currently participating in CMS's bundle payment care initiative models 1, 2, and 4 within Phase 2 are excluded from the mandatory participation in CCJR. The big change with CCJR is now hospitals are accountable for the quality and costs for the entire episode of care. At a high level, depending on the results of the quality and cost performance of these episodes of care, the hospital may receive a reconciliation payment back from Medicare, or it could be required to repay Medicare for a portion of the episode cost. The model is expected to save Medicare $153 million over the course of 5 years.
So, Michelle, how much does that represent?
Well, there's approximately 800 hospitals in the CCJR geographic regions. That equates to 111,000 procedures annually. So that's about 25% of all hip and knee replacement surgeries currently performed under Medicare. So the $153 million represents only 1.2% of the $12.3 billion Medicare expects to spend on these procedures over the next 5 years. The episode starts with the admission of hospitals falling within DRGs 469 and 470. So admission starts the episode. This includes not only primary hip and knee replacements, but also the partial hip replacements, procedure code 8152, sitting within these DRGs. This episode includes all services paid under Medicare Part A and B from time of admission to 90 days post-discharge. Examples of these services include physician services, inpatient admissions and readmissions, skilled nursing facilities, home care, and outpatient therapy. You can see them listed on the right side of your screen. There are a limited number of exclusions. As an example, acute clinical conditions arising from existing chronic conditions unrelated to the joint replacement is considered an exclusion. Also, those drugs paid outside the MSDRGs, such as hemophilia clotting factors, are excluded from the episode definition. So in summary, you're looking at DRGs 469 and 470 from admission to 90 days post-discharge. So these are the defined 75 MSAs, or geographic regions. These are core urban areas with population of at least 50,000. These 800 hospitals in this region range in size, location, population, and cost. It is important to note that critical access hospitals are currently excluded from the mandatory participation. And you know, Brian, as I look at this map, it looks quite similar to the Blue Cross map that you previously shared that demonstrated the variation in cost.
Yeah, it does. If you look at those bubbles, it certainly does represent it. But I'll also tell you, Michelle, that this also represents many people who have registered for this web seminar. And quite frankly, it also represents several of the conversations we've been having recently with hospitals that are located in these markets.
So in the proposed rule, payment to the individual or location of care occurs in the same manner as they do now. So I think that is worth stating again. Initial payments to the providers will remain the same, and that's for these 5 years. Nothing will change for the providers for the episode of care. That said, CMS will migrate to a regional pricing structure in order to set the target price for the entire episode of care. CMS proposes to calculate each hospital's preliminary episode target price based on 3 years of historical data. So in years 1 to 2, the episode payment will be determined by 2/3 hospital-specific and 1/3 regional payments. In years 3, they will move to the reverse, 1/3 hospital-specific and 2/3 regional pricing. And finally, in years 4 and 5, it will solely be regional pricing. So while the hospital regional pricing is established, it is also proposed that there will be a 2% decrease in the target episode price for years 1 through 5. So you have multiple factors occurring here in terms of the payment structure. So to reiterate, the payment structure for physicians, hospitals, and post-acute care facilities does not change. What will change, however, is the reward or the penalty payment. So in addition to moving towards regional pricing, there is an opportunity for the reconciliation payments or rewards in which the hospital will receive money back, or penalties in which the hospital then owes Medicare back. Reconciliation payments are then capped at 20% of the target price or a stop gain. Penalty or repayment to Medicare will be phased in and capped for a stop loss. The good news is that in year 1, there's no penalty for the hospital. You don't have to pay Medicare back. In year 2, the penalty payment is capped at 10% of the target price. Year 3 to 5, the penalty payment is then capped at 20% of the target price.
Okay, so for those of you on the phone, Michelle just provided a very good overview of the structure and the mechanics of CCJR. Now what we're going to get into, and Michelle, if you could move forward with it, you know, what's in it in the numbers? Can you quantify some of the opportunity that's there?
Sure. I will provide you with an overview and then some specific examples to help tie that number to a meaningful representation. So for demonstration purposes, we've chosen $25,000 as the hospital-specific regional average blend, or the target price. This may appear a little high, but you need to consider the impact of partial hip replacements on DRG 469 and 470. And quite honestly, $25,000 makes for an easier math problem. So let's look to understand the risk versus penalty at this rate. The stop gain is 20%. So if your episode costs are $20,000, you have the opportunity to be rewarded and receive money back up to 20%. So that's the good news side. Now let's look at the flip side, and your episode of care costs are higher than the target price. Remember, year 1, no penalty for higher costs, which allows you to get your hands around the full episode cost. In year 2, the max penalty is capped at 10%. So even if your costs are $30,000, you will only be penalized at $27,500. So you're not capped at that full $30,000. Now, year 3 to 5, the max penalty is 20%. So the penalty will be higher, and you could be penalized at the full $5,000 amount if your costs were $30,000. So that's a lot of math here Let me give you some examples that might help create some more meaning. So in this example, your year one costs $21,000. And let's say the target pricing remains at $25,000. So for a hospital providing care for 500 Medicare joint replacement cases, the savings per case would be $4,000, and you get that from $25,000 at the target price minus $21,000, which is your episode of care. So the total savings would be $2 million to Medicare over those 500 cases. And because $21,000 is within the 20% stop gain amount, the hospital has the opportunity to receive $2 million in reconciliation payment for those 500 cases. So that's a good news slide, if you will. So for example 2, we're looking at year 2 costs of $28,000. Same 500 cases, and the target price remains at $25,000. This creates an excess cost per case of $3,000. At 500 cases, that is a total excess cost of $1.5 million. That $1.5 million is more than the 10% stop loss amount in year 2. So therefore, your penalty is $1.25 million, and you're not penalized on the full amount because of the 10% stop loss. So that helps you in year 2. Last example, we're at year 3. You've been able to reduce your cost down to $26,000. We'll keep the target price at $25,000 and 500 cases the same. So now your excess cost per case is $1,000. That's the $26,000 minus the $25,000, giving you an excess cost per case of $1,000. So at 500 cases, this creates a total excess cost of $1 million. In year 3, now there's a 20% stop loss, of which this is less than, so the hospital will then be penalized the full $1 million amount. So that was a lot of information, but I hope that creates more understanding of the methodology that CMS has imposed. So now that we've tied those dollars to the impact, how is the reward and risk structured? Well, let's remember first off that quality metrics are also tied to the CCJR performance. So in order to receive a reconciliation payment, you must not only achieve complication and readmission metrics, but HCAHPS performance as well. In years 1 through 3, you must be at the 30th percentile, but in years 4 through 5, you must achieve at least the 40th percentile. Also to note, CMS is also financially incentivizing participating hospitals that submit data for certain patient-reported outcome measures related to total hip and total knee. So they are looking at quality metrics, patient experience, and functional outcomes in addition to the episode cost. So let's talk about how this can impact the providers within the episode of care as we look at how the reward and risk can be shared. Participant hospitals have the opportunity to share their reward or the risk with the collaborators. Collaborators include physicians and post-acute care providers. So in order to achieve the reward or the risk, these collaborators are required to engage with the hospital in care redesign strategies for internal cost savings. Sharing of this reward or risk is limited to 50%, and no more than 25% of the repayment responsibility can be shared with one provider. So let's just assume the reward for a lower cost episode of care is $1 million. The hospital can keep $500,000 and share $500,000 with the collaborators as a way to engage them in the improvement process. And remember, only up to 25% can be shared with one provider. So prior to the gain sharing payment or receiving of the alignment payment, participating hospitals and CCJR collaborators must enter into a written participation agreement. So there are legal ramifications surrounding this process. So a few other points to keep in mind. Hospitals in the CCJR can also participate in an ACO at the same time. And there are a few waivers attached to this proposal. As an example, CCJR will waive the skilled nursing facility 3-day rule following the patients meet the appropriate clinical criteria. And the SNF that you are referring them to has a 3-star or better rating. So that helps manage some of your internal cost savings with a length of stay management approach. Home health visits and telehealth are two additional waivers provided within the proposal. It's critical to remember that with the collaborator payments, some financial arrangements may implicate federal fraud and abuse laws, so it's important to get legal feedback on the participation agreements. So in summary, that is at a high level what the CCJR approach will be occurring with the payments and the risk models all defined.
Great.
So I'll turn it back over to you, Brian.
Thanks, Michelle. All right, so for those of you on the line, Michelle provided you some very good structure to CCJR. But Michelle is also able to provide with some examples that we expect will provide a little more color to CCJR. But what's going to be important here is that you're looking at your pie. Do you know your cost? Do you know what your quality breakdown looks like? So if you don't know, this breakdown is a very important component of what Accelero does for its customers and markets across the country. And this is a typical breakdown of what we see for DRGs 469 and 470. Now, we know a lot of the focus is going to be on the total hits and the total knees. That makes sense. It's a big part of the business, right? But the point here is don't lose sight of those partial hits. It's only 10% of the volume, but look at the impact. If you look on the slide in terms of the impact of length of stay, the coded complication rate, the impact is pretty significant for 10% of the business. And so managing partial hips will go a long way in hitting your length of stay, your complication rate, and also your cost metric goals. And in this slide, we see partial hips, right? We know that they have a high rate of using skilled nursing. In turn, we've seen the studies that show skilled nursing has a higher chance of readmission versus, say, home or home health care. And because of this, more and more of our customers are asking us to help them with their hip fracture programs. So take a look at this slide, and you can see some of the differences between partial hip, and total knee replacement. Now let's take a look at what the cost picture looks like. Okay, so this slide represents total joint replacement. It's the $22,000 payer cost. Now remember, the cost to the payer is what they pay out. And we feel pretty good about these numbers, especially since Medicare estimates that 55% of the episode of care costs lie in the hospital anchor admission. But it'll be important for you to look beyond the hospital cost. More specifically, you need to look at the opportunity in readmission and in the post-discharge care. And when you look at it through the lens of a bundle payment, there are some real compelling dollar savings. There's some real compelling opportunities situated in those two buckets. And it's a very similar story for those hip fractures. Again, our data tells us the cost to the payer is around $24,000 to $25,000. And again, look at the post-discharge. Look at the readmission costs. Again, real opportunity. So we've discussed the what, okay? We've discussed the where the cost savings is, where the opportunity is. Now let's move on to the how. And in the next 15 minutes or so that we have left, Michelle's going to walk through the 5 keys to success for bundle payment.
Thanks, Brian. Regardless of CCJR going live in January or not, alternative payment models such as bundle payment is not going away. So as Brian mentioned, let's talk about how you can position your organization for success for bundle payment. You will see here 5 keys to success, and I will go into the detail in subsequent slides. But as an overview, first you need to establish a strong infrastructure. Second, you have to have access to data to drive operational decisions. Third, establish goals for benchmark performance for operational, clinical, and patient experience outcomes. 4, reduce variability of care in order to drive to a predictable cost and outcome. And lastly, 5, integrate with post-acute care facilities such as skilled nursing facilities, home care, and outpatient PT to establish care plans. So we'll take those one by one. Let's start with infrastructure. The infrastructure of your program established the vision, the goals, and the process for improvement. While the leadership team is critical to establishing expectations, we recommend you have process teams to really drive the implementation of change. So when we first start to work with a hospital, this is really one of the first places we start, and that's creating an infrastructure. We've seen this multidisciplinary process team work very well when clearly defined goals are established. Some examples of these teams include an outcomes team with focus on improving clinical complications, functional outcomes, patient satisfaction, and readmissions. Having a perioperative team to drive process efficiency and surgeon satisfaction. A care process improvement team is really responsible for reducing the variability of care in elements such as length of stay and discharge. Post-acute care integration team is establishing care plans and discharge requirements after patients leave your hospital or anchor admission. And with this bundle payment project, you can see that that post-acute care integration is really the newest team to be established. So in order for these teams to be successful, you must have physician engagement as well as transparency with data. As an example of the value of engaging physicians, I point you to this article found in the Journal of Arthroplasty in March of 2015. It further emphasizes the need to involve surgeons in the process. A couple of key points from this article are that most believed the bundled payment is the best way to improve quality and reduce costs over fee-for-service and employment models. 94% expressed concern that bundle payments could provide a disincentive to surgeons to operate on high-risk patients. And 75% had concerns about the uncertainty of revenue sharing as a barrier to implement alternative payment models. So there are some real concerns here expressed by the physicians with this AAHPS membership survey. Alternative payment models provide uncertainty, and we encourage you to engage your physicians in the types of payment models your organization is being challenged to implement. Provide education and encourage your physicians to participate by reviewing data and implementing change process. Having access to data and provide transparency to your teams allows for informed operational decisions to be made. Accelero helps our hospital partners have access to data through our business intelligence tool, OrthoVal. This is an example of a joint replacement dashboard that is available to our partners with each monthly data upload. So in one place, you have the opportunity to review operational, financial, and clinical metrics. You can trend all of these elements, including volume and overall volume by surgeon, variable cost, contribution margin, length of stay by day, complication rate, discharge disposition, and payer mix. So all of that is in one place. And to review that on a monthly basis can really be powerful. OrthoVal also allows for data reporting, so those members of the process improvement teams not only have this overview to evaluate the data, but they can drill down into specific patient accounts for root cause analysis. Whatever the process within your organization, I encourage you to share data with those who can improve results.
Yeah, thanks, Michelle. And this is a hospital where we recently did an assessment. And when we went in to do the assessment, there are a lot of things we look at. One area that we look at is the HCAHPS scores. And this is where they were at hospital-wide when we came in. And if you go back to Michelle's slide and the key points she made on the quality component, if the HCAHPS scores dip below the 40th percentile in years 4 and 5, the hospital is at risk to lose its reconciliation. This hospital stands to risk its reconciliation given where it's at today. So yes, you absolutely need to focus on the readmissions, and yes, you absolutely have to focus on the post-acute care. But we're trying to give you some other angles that you have to make sure you're looking at all these areas. So you can't leave out, Michelle, that focus on the patient experience.
Absolutely, and you're right. It will impact your reconciliation payment, let alone the impact to the patient experience at its root level. So when we work with hospitals, our team really helps drive patient experience. As an example, we'll work to improve pain management or improve the messaging that the patient hears from the point of surgical decision-making in the physician's office to what they hear in the joint class, so they can be prepared for discharge. These scores can move as a result of improvement strategies. Another key metric to evaluate at your hospital is the complication rate, since this is one of the quality metrics tracked by CCJR. This slide demonstrates the information available on Hospital Compare. So this is transparent to anybody who looks at information on the website. You can see in this example that the national average of complications is 3.1. This hospital has a complication rate of 4.7. So Medicare is looking for specific complications at defined time periods, from admission to 30 days. Elements such as AMI, pneumonia, sepsis, pulmonary emboli, wound infection, all of those are being tracked. We know that the cost for complication can cost between $1,500 and $1,800 per case, with about 58% of that being attached to the additional length of stay required, and the rest being attached to the care provided related to the complication. So it's really twofold where you have an increase in cost. So while Medicare looks at a very refined list of complications, Accelero uses a broader definition of complications during the anchor admission. This definition is obtained through the use of industry standards, inclusive of Medicare and others such as Joint Commission and health grades. We also have identified trends that impact process and care outcomes for total joint replacement. So all of those complications are included in our ability to evaluate hospitals. You can see the variation of complication rates within our comparative database, which does contain about 25,000 annual joint replacement cases. So not only does this impact the quality of care, but it also impacts the cost to provide care during an anchor admission if you're looking at the 90th percentile compared to the 25th percentile. Significant impact.
Yeah, we've talked a lot about quality, we've talked a lot about discharge, but again, we're trying to provide you with some other angles to look at. And if you're looking to shave additional hospital costs, that 55%, the OR may be your opportunity because that usually accounts for about 25% of the hospital cost. And this slide shows 3 areas where we see significant opportunity and variability because our perioperative team, we've got a dedicated team that works exclusively in this area. When they're working with our customer, these are some of the metrics they're working towards moving so that they can create capacity and additional throughput in the OR. And here's what it can look like. This is the difference between 3 and 5 cases. So, getting 2 additional cases onto the OR schedule can be significant. And if you look at the top one, look at the 3 cases, the direct OR cost per case. Now look at the bottom, at the 5 cases, the difference in OR cost per case for those 5 cases, okay? Now you start to do the math, and you start to look at that across a week, a month, or even a year. It really starts to add up, and it's significant. And beyond the cost, you also see the picture from the reimbursement side, not just for the hospital, but also for those surgeons working in your hospital. It can be very, very meaningful.
So as an example of another process metric that our hospital partners track, it is length of stay of 2 days or less. As the geometric mean length of stay continues to decline each year, for 2016, the DRG 470, the geometric mean length of stay is projected to be 2.8. So it becomes more important to manage to that 2-day length of stay. Our benchmark performers are able to achieve a 2-day length of stay with 77% of their patients, compared to those at the 50th percentile only achieving this with 41% of their total joint replacement cases. You can see there is a range of variation between the 90th and the 25th percentile, and it really goes without saying that it is important for patients to achieve clinical and functional discharge criteria in order to meet this 2-day goal. Accelero works with hospitals to ensure care is accelerated to achieve this goal. So you can create internal cost savings while achieving the same or better outcomes for your patients. So one other key opportunity that I had identified was reducing variability of care. There's a lot of information on this slide. What we're talking here is to reduce variation of care in order to achieve a predictable outcome for your patients and create consistency in cost. Both are wins. Here's an example of a hospital Accelero evaluated. Each column represents a different surgeon's results. Key areas of variation exist in discharge in 2 days or less, for example. You can see that Dr. F is at 35% compared to Dr. A with the highest volume, only getting 2% of his patients out in 2 days. So it's easy to see that there's a difference in the philosophy of care. Looking at percent of patients being able to be discharged home, you can see clear variation between 23% and 63%. It's important to note the variation in coded complication rate, with a wide variation between 0% to 9.2%. So in this one slide, you can see it's very important for hospitals in order to manage operational change is to understand the details, and it's at this level where you look at not only averages, but looking at the information by physicians that you'll be able to drive that change.
Yeah, so Michelle, when you see this as an example, when our teams walk into a hospital, they've got this level of variability, what is it that the Accelero team's working with the hospital to reduce some of that variability and, really get behind the numbers here?
Sure. So one of the first places to start is to understand where the order sets are. Is there one order set, or does each physician follow a different playbook, if you will, for the care of their patients? Remember, not only is the order set important for the physician, but it's the care pathways in which all of the care providers really react to that order set. So we look at order sets and care pathways with information such as looking at multimodal pain management protocols so that you can have not only outstanding patient experience, but also accelerate their rehabilitation so that they can achieve that 2 days and home. It's also important to look at the messaging for the patients. As soon as you tell a patient that they may go home or go to a skilled nursing facility, they start planning for the worst. What we know is that if you prepare a patient to go home and they understand the clear criteria that enables them to go home and they can start to check off items 1 through 10, then you put the discharge really in their hands, and it allows them to be empowered with the ability to request, will I be going home tomorrow? I see I've met all of the criteria. Complete paradigm shift for patients as well as the care providers and the case managers, for example.
Yeah, thanks, Michelle.
So getting to another metric, it's the cost of readmissions. And similar to complication rates, readmissions are also tracked for 30 days by CMS. Now recall what Brian mentioned. Readmission and post-acute care are key opportunities to reduce costs for the episode of care. The average cost of readmissions can range from $13,000 for a total knee replacement to $17,000 for the total hip replacement. In this hospital example, the readmission rate is 6.9 compared to the national average of 4.8%. So let's apply the math to this example. So keeping the math simple, using 500 cases and an average cost per readmission of $15,000, taking a hospital from 6.9% readmission to an all-payer readmission rate of 3% could contribute close to $300,000 in payer cost savings on readmission alone. So of course that does not happen by accident. You have to implement strategies that will reduce readmissions. And discharging more patients to home certainly has an impact on your ability to reduce readmissions. So as we look at reducing post-acute care utilization, it is important to establish goals for getting your elective hip and knee replacement patients home. Hospitals in Accelero's database at the 90th percentile are able to discharge 87% of their patients home. On the flip side, hospitals in the 25th percentile are absolutely incurring additional post-acute care costs compared to the 90th percentile. So when you're looking at the full episode of payment costs, remember what we mentioned earlier, looking at post-acute care costs and readmissions are really two of the highest areas of opportunity for variation. So let's look at some examples of cost impact when you look at various post-acute care models. So in this scenario, you take, for example, a total knee replacement patient going from the anchor admission to a skilled facility and staying 30 days, that becomes a cost of almost $13,000. After discharge, it's common to have home care come and see the patient for approximately 2 weeks. That gives you an additional cost of $1,100. And then for further strengthening, the patient receives 6 visits in outpatient physical therapy. So the total cost for this post-acute care episode is $14,580. Now let's look at another example. In this example, the patient goes directly home. So they go from the admission, they're staying 2 or 3 days, and going directly home and receiving 2 weeks of home care services. They also then, after their home care is Finished, then they go to an outpatient physical therapy facility for 4 weeks of 2 times per week visits. The total cost is over 80% reduced with this model compared to the example I just gave you. If a patient meets the clinical and functional criteria for discharge to home, costs can be greatly reduced without negatively impacting the outcome for this patient. So 2 key examples of how we see patients move through the episode of care. So the 5th step to integrate that I had mentioned for improving your process for bundled payment care is to integrate with post-acute care facilities. This doesn't just apply to skilled nursing facilities, but with home health agencies and outpatient physical therapy facilities. Now more than ever, hospitals need to ensure their patients receive appropriate care, leading to extraordinary outcomes. We have seen the following approaches be effective when working with post-acute care facilities that you are discharging your patients to. Establish an effective handover process. You need to ensure they understand the whole patient, clinically, functionally, and socially. Collaborate to define care plans that meet the expectations for your patients. So the care process that you have started along the acute care process needs to be transferred to that post-acute care facility. Define clinical and functional criteria to ensure they transition to the next level of care in a timely and efficient manner. So if you are sending your patient to a skilled nursing facility, set the criteria of when they should be discharged to home health, and from home health going to outpatient physical therapy. Create a process for clinical evaluation before transferring the patient back to the hospital ED. This is really critical. Unnecessary utilization of the emergency department and subsequent readmissions can be prevented if the surgeon, the physician assistant, nurse practitioner is called to transfer, prior to the transfer, to review the signs, symptoms, and approaches to care from that skilled nursing facility. So I can't emphasize that point enough. Ensure that you have a process where the clinical evaluation can occur before they are transferred back to the hospital. And partner with your post-acute care facilities and establish report cards where skilled nursing facilities are reporting items such as length of stay, outcomes, and readmissions to you on a routine basis for this patient population. Remember, this whole episode of care starts with the hospital admission, and we're really challenging the hospital to be fully responsible not only for the cost because of a CCJR, but for the entire care for the episode of care because these are your patients.
Great. Thanks, Michelle. That's a lot. And there's a lot going on, and no one's 100% sure what's coming around the corner, right? But when we do turn the corner, you know, that light, that could be the light of the day, or quite frankly, that can be a train coming. We encourage you to be ready for the train. We encourage you to keep the focus, stay on the path. We hope that today we've provided you with some good context, some good examples to have some of these discussions with your team. We also hope that you've discovered some additional keys to your team's success. Now, a few things before we jump into the Q&A. One is, Accelero, we welcome the opportunity to continue the discussion with you and your team. If you're interested, go on our website. You can contact us via phone or email. You can ask for me specifically, Brian Crowley. I'll make sure we get the right resource in front of you. We'll jump on the phone, we'll jump in a car, we'll jump on a plane to come have that discussion with you and your team. Also, this web seminar, a taped version in the next, say, several days to a week, will be provided on our website. If you go to the Orthopedic Insights link on our website, you'll find all of our web seminars as well as white papers, success profiles, and a lot of information that I think will be good resources for you and your team. So I encourage you to look at that, again, as you're having some of these discussions going forward. So with that said, I'm going to throw it back to the operator for some Q&A.
Thank you. Ladies and gentlemen, at this time, we will now begin the question and answer session. And our first question comes from the line of Stephanie Lane with Cox Health. Please go ahead.
I was wondering if total ankles are included in the 469, 470.
That's a great question, Stephanie. For the CCJR bundled payment, they are qualifying it by only DRGs 469 and 470 only. So all procedures inclusive of total ankles would follow underneath DRG 469 and 470. Okay. So total hips, total knees, partial hips, and then if you have total ankles being performed, they would also be in there.
Okay. All right. Thank you.
Sure.
And our next question comes from the line of Stephen Miller with Florida Hospital, North Pinellas. Please go ahead.
Yes, my question is in regards to I noticed the 3-day minimum stay would be waived under this program. I also wondered whether there was consideration given for the reduced payment for the DRGs under the acute care side.
Let me make sure that I understand your question. You've noticed that there was the 3-day minimum stay for the skilled nursing facility is part of the waivers, but then help me understand the reduced payment for the DRG. Explain that a little more.
Currently, if a patient is discharged less than the geometric or several days less than the geometric, there's a reduced payment to the hospital. And I just wondered whether that also was part of the waiver or that would continue as currently implemented by CMS.
Yeah, so you're referring to the transfer rule. That's a great question. It is my understanding that with the as a skilled nursing facility waiver will occur within the 3 days, that is only based on the clinical criteria. So that's one part of it. The transfer rule itself really becomes less and less specific since the Medicare is only paying on a 2-day length of stay now. So you would really have to discharge your patient to a skilled nursing facility on day 1 in order to have a reduced payment model. So if you keep them 2 days, you get the full payment, and you can still beat the 3-day rule for the waiver that is applied.
Got it. Understand. Thank you.
You're welcome.
And there are no more questions in the queue.
Okay. Great. Well, everyone, thank you again for the opportunity to share with you some of this information today. Again, we look forward to continuing the discussion, and please, if you have any questions, please go out to our website and you can contact us directly. Again, we would love to continue that discussion with you and your team. Everybody have a great afternoon, have a great evening, and we look forward to our next session. Take care.